Good day, everyone. I would like to welcome you to my presentation. My name is Łukasz Zważany, and I am a radiologist at the Department of Diagnostic Imaging and Interventional Radiology at the Pomeranian Medical University in Szczecin. Today, I am here to talk to you about the clinical applications of artificial intelligence in neuroradiology. In recent years, there has been a growing interest in how AI may be applied in medical imaging. This may be reflected by showing the rise in the number of published papers regarding AI and diagnostic imaging. Neuroradiology is the most highly represented radiology subspecialty in these papers, accounting for approximately one-third of all such articles. As we can see, approximately 3,000 papers published in the year 2020 may be identified in the PubMed database using the search of brain and AI or machine learning or deep learning. This is almost a six-fold increase compared to the number of articles published in the year 2005. The influence of neuroradiology in AI research may be attributable to a variety of factors. First of all, neuroimaging comprises rich, multidimensional, multi-contrast, and multimodality data that lend themselves well to machine learning tasks. Secondly, there are well-established neuroimaging public datasets, including Alzheimer's disease with the Alzheimer's Disease Neuroimaging Initiative, or brain tumors with the Tumor Cancer Imaging Archive. Furthermore, there has been quite a long history of quantitative research in neuroimaging. Historically, neuroimaging has been at the forefront of imaging innovations, which may attract researchers to this radiology subspecialty. Finally, there is a myriad of problems in neuroimaging yet to be unsolved. There are three major impacts that AI applications may have on the work of radiologists. They can support our workflow, making us more productive. By support, we understand that the functionality of AI application helps some inefficient tasks but does not fundamentally change the primary workflow. The interference of human actors, in this particular case neuroradiologists, is still required, and the workflow is still the same. The example of such functionality would be of how images and clinical information are displayed to the reporting radiologist. Secondly, AI applications can extend our capabilities so we can provide more information to the clinicians. By extend, we understand that AI application offers a functionality that was not previously performed by radiologists or the previous systems, and now, with this new functionality, a new task is added to the work and may require the improvement of human capabilities. With such applications, we provide diagnostic information that was not available before. Finally, we can theoretically be replaced, at least in performing some of our tasks, by AI applications. In a recent review, 37 commercially available AI applications for neuroradiology have been identified. The authors reported that 35% of these applications have been approved both by FDA and CE. 68 of the applications have at least one type of approval, and 32% of applications have not been approved yet. Half of the applications offer some kind of scientific proof to show their validity. Over 60% of the applications have been designed to investigate the images of patients with either ischemic stroke or intracranial hemorrhage. Other applications were designed to be used for mild cognitive impairment and dementia, multiple sclerosis, brain tumors, traumatic brain injury, Parkinson's disease, and intracranial aneurysms. The authors evaluated the functionalities of the identified AI applications and stated that over half of them support the work of neuroradiologists. An example of such supporting application may be an application which automatically calculates the aspect score from CT images of patients suffering from acute ischemic stroke. 32% of functionalities were assessed as being able to extend the possibilities of radiologists by providing quantitative information about pathological findings. And there are several commercially available applications which provide volumetric information about the brain structures. Data provided by these applications might be found to be useful for clinicians dealing with patients with dementia, multiple sclerosis, and many other neurological conditions. Up to date, none of the available AI applications can replace the entire radiology profession. Only a small part of them can take over some task. An example in this case might be an application which automatically alerts the on-call stroke team after the large vessel occlusion is identified in a patient with acute ischemic stroke. There are many possible functionalities that AI applications for neuroradiology may have. They may provide quantitative information about pathology. They can mark region of interest or detect change. They can provide classification, diagnosis, or outcome probabilities. They can derive brain biomarkers. They can optimize workflow and triage imaging studies. They can also perform fast anatomical segmentation. Some of them can already be used in daily clinical practice, but others await scientific validation and further development. In the next part of my talk, I would like to present to you what have already been achieved with AI in the field of neuroradiology. Let's start with intracranial hemorrhage. Early diagnosis in this critical condition is very important since mortality is highest in the first 24 hours and early treatment likely improves outcomes. CT is the most widely used imaging modality in this condition, and time of diagnosis largely depends on how quickly a brain CT is interpreted by radiologists. Although inpatient studies with high priority are usually reported fast, there is an inevitable threat of delay in outpatient studies, especially in the setting of limited radiological workforce. These patients may unfortunately also present with intracranial hemorrhage, for example when they are on anticoagulation therapy. A recent paper showed that AI may be used to optimize workflow in the radiology department. A deep learning model was developed to detect intracranial hemorrhage. It was trained on over 37,000 head CTs and achieved high accuracy, despite the heterogeneity of the data and variety of intracranial hemorrhage cases. The algorithm was used to reprioritize radiology worklist. And during the study period, it identified 94 routine head CTs with possible intracranial hemorrhage and upgraded them to the higher level of priority. In 64% of these cases, interpreting radiologists confirmed the diagnosis of intracranial hemorrhage. Due to the implementation of the algorithm, median time to clinical interpretation in these cases was 19 minutes, which was considerably lower than 512 minutes for routine head CTs. Furthermore, approximately 10% of the presumed false positive cases were subsequently identified as showing probable hemorrhage by the staff neuroradiologist overreading the studies. Another group created a 3D convolutional neural network that does not only detect intracranial hemorrhage, but also classifies patient CT scans into different acute hemorrhagic variants, including subarachnoid hemorrhage, intraparenchymal hemorrhage, acute subdural hemorrhage, and brain polytrauma hemorrhage. In this study, the AI solution discriminated between 4 different types of intracranial hemorrhage with an overall F1 score of 0.684. There are also commercially available AI applications for intracranial hemorrhage detection. In a recent paper, FDA approved commercially available AI solution based on a convolutional neural network was used to assess the prevalence of intracranial hemorrhage in brain CT scans, which were originally reported as negative. This tool was applied to 5,585 such CT scans and suggested intracranial hemorrhage in 28 of them. The diagnosis was confirmed in 16 of these cases by a consensus reading by 3 experienced neuroradiologists, setting a false negative rate of radiologists for intracranial hemorrhage detections at 1.6%. This study demonstrates that the use of AI solutions can minimize false negative rate for intracranial hemorrhage detection. Acute ischemic stroke is a neurological condition for which the greatest number of AI applications have been developed. We all know the phrase "time is brain," which means that brain tissue is rapidly lost as stroke progresses and emergent evaluation and therapy are required. The Alberta Stroke Program AIneurorCT score aspects is a 10-point quantitative topographic CT scan score used in patients with middle cerebral artery stroke. It subdivides the brain territory supplied by MCA into 10 different regions. For any evidence of ischemia in one of those regions of interest, 1 point is subtracted from 10. It has been shown that lower aspect score predicts worse functional outcome. Recently, several AI applications have been developed for automatic aspect score calculation to support radiologists in fast image interpretation. In a study from 2018, one of the commercially available applications has been validated. This application was used to evaluate 119 CT scans of patients with acute MCA ischemia, which were also reviewed by 3 neuroradiologists. The results show that aspect score determined by neuroradiologists had higher correlation coefficient with definite infarct core compared to aspect score calculated by the application. This was especially true for the cases in which there were some pre-existing brain changes. In the other paper, however, it has been shown that aspect score calculated with automated software had better agreement than that of human readers with a predefined consensus score. Recognizing large vessel occlusion is one of the major tasks of radiologists when evaluating patients with symptoms of acute ischemic stroke. There are commercially available applications for automated large vessel occlusion detection, and the reported sensitivity and specificity are quite high. Furthermore, they are capable of automatic notification of a large vessel occlusion alert to the on-call stroke team. One of the commercially available applications does it with a median time to notification of 5 minutes and 35 seconds. Definitely, such solutions may reduce time to treatment, with better outcomes for patients. Another possible application of AI in patients with acute ischemic stroke is infarct prognostication. In a recent study, a deep convolutional neural network investigating 9 MRI biomarkers was used to predict final infarct volume. It yielded a significantly better performance in predicting final outcome than current state-of-the-art methods, including thresholds-based methods. The authors of the study stated that such improved predictions may lead to personalized treatment and thereby better outcome for the individual patient. AI applications may also be used to predict clinical outcomes for patients with large vessel occlusion who undergo mechanical thrombectomy. In a recent study, a deep learning model was applied to predict clinical post-treatment outcomes using pre-treatment DWI on patients who underwent mechanical thrombectomy. The predictions of clinical outcomes using this approach were significantly superior to predictions based on DWI aspect scores and estimates of the ischemic core volume by manual segmentation. AI has also found applications in imaging of patients with multiple sclerosis. MRI is routinely used for both diagnosis and follow-up of multiple sclerosis. A hallmark of the disease is the presence of plaques, which are hyperintense lesions on T2-weighted and FLAIR images. Accurate detection of MS plaques is a key component for clinical assessment of disease stage and prognosis, as well as for evaluating the efficacy of treatment during clinical trials. Manual detection of lesion is very time-consuming and sometimes lacks accuracy. That's the reason why many machine learning and deep learning models have been developed for multiple sclerosis plaques detection and segmentation. The precision of this model is reported to be as high as 19%, which can be considered to be at least as good as that of manually rated scans. Enhancing plaques on MRI scans obtained after contrast agent administration are considered to represent an active disease in multiple sclerosis patients. This is why they undergo frequent MR imaging with contrast agent administration for regular clinical follow-up. However, there are some concerns about gadolinium-based contrast agents administration, including long-term gadolinium deposition in various tissues. Therefore, it is desirable to develop methods that can predict enhancing lesions without the use of contrast agents. In a recent paper, a deep learning model was described which was able to predict plaque enhancement with moderate to high accuracy, basing only on its appearance on non-contrast sequences, including T1, T2-weighted, and FLAIR images. Let's move to intracranial aneurysms. The prevalence of this vascular pathology is estimated to be around 3% of general population. Subarachnoid hemorrhage from aneurysm rupture is a devastating condition with high morbidity and mortality rates. Although aneurysm size is considered to be one of the most important risk factors for aneurysm rupture, a significant number of aneurysmal subarachnoid hemorrhages is due to small aneurysm rupture, and this, unfortunately, can sometimes be missed by radiologists. AI solutions may aid radiologists in the interpretation of time-of-flight MR angiography and detection of brain aneurysms. Develop deep learning models for automated detection of brain aneurysms on time-of-flight angiography have sensitivity as high as 94% with a rate of 2.9 false positives per case. AI has also potential to aid radiologists in spinal imaging, and several applications have been proposed. As data from literature shows, incidental osteoporotic vertebral fractures are often underdiagnosed and underreported. Reporting this finding is important as early diagnosis and treatment are critical to prevent further fractures and morbidity. It has been shown recently that deep neural network is capable of detecting osteoporotic fractures on chest, abdomen, and pelvic CT scans with accuracy of approximately 90%, which is similar to the performance of practicing radiologists. Cup angles are widely used for scoliosis diagnosis and treatment decisions. The procedure relies on clinicians to identify the most tilted vertebra and plates on the X-ray images, and then measuring the cup angles between those vertebrae. It is known, however, that manual measurements of the cup angles suffer from high inter- and intra-observer variability, and they are also time-consuming. In a paper from 2019, a deep learning model for automated measurement of the cup angles was described. It achieved high accuracy with high correlations between the automatically estimated angles and the manual measurements performed by two spinal imaging experts. Another group developed a deep learning based program for automated segmentation and quantification of the vertebrae and intervertebral discs on lumbar spine MRIs. Such quantitative measurements may improve the assessment of degenerative changes of the lumbar spine. The agreement between the software and manual segmentation for both the vertebra and intervertebral discs was excellent. The software performed the measurements in a half of a second. There is also a great variety of possible AI applications in neuro-oncology. In a recent meta-analysis, it has been shown that developed machine learning models demonstrated an excellent diagnostic performance for prediction of IDH mutation in glioma. Unexpectedly, machine learning that used conventional MRI sequences demonstrated higher specificity in predicting IDH mutation than that based on conventional and advanced MRI sequences. Finally, integration of clinical and imaging features in machine learning yielded a higher sensitivity and specificity than that achieved by using imaging features only. Recent study has shown that deep learning network can automatically detect and segment brain metastases on multi-sequence MRIs with high accuracy. Such software would definitely be useful in the clinical management of patients with brain metastases. Assessment of initial tumor volume and volume change in relation to disease progression or therapy are key neuroradiological findings to report. However, manual detection and segmentation of brain tumors can be a tedious and time-consuming task, particularly with the growing use of multi-sequence 3D imaging. Therefore, AI solutions for automated detection and segmentation of brain tumors will be undoubtedly beneficial for radiological workflow. AI applications may also have a potential use in the setting of acute trauma. McCoy and co-workers developed a 2D convolutional neural networks for automatic segmentation of the spinal cord and traumatic contusion injury from axial titulated MR imaging in a cohort of patients with acute spinal cord injury. Compared with manual labeling, a developed deep learning model achieved high accuracy. Interestingly, the contusion injury volumes based on automated segmentation were significantly associated with motor scores at admission and discharge. Traumatic brain injury is a complex and diverse medical condition with a high frequency of intracranial abnormalities. For patients with traumatic brain injury, CT is an imaging modality of choice, providing information whether there is a need for operative intervention. In a paper from 2019, a deep learning model was presented that automatically detect and quantify intracranial traumatic lesions, cistern volume, and midline shift. The results of this study are really promising as there was high correlation between expert assessment and the developed software. Such quantification of the extent of intracranial abnormalities may for sure provide added value in routine clinical practice. AI may not only aid radiologists in post-processing of the images, but it can also provide interesting solutions for other stages of radiological workflow. Brown and co-workers have shown that AI tools may be employed to aid in clinical decision support for protocoling and prioritization of MRI brain examinations. Based on the narrative clinical information provided by the referring physician and demographic data, the natural language processing models achieve quite high accuracy for selecting an examination protocol, evaluating the need for contrast agent administration, and determining priority. Furthermore, we all know that there are some concerns over gadolinium deposition from gadolinium-based contrast agents administration. It has been shown recently that with the implementation of deep learning method, gadolinium dose can be reduced 10 times fold while preserving contrast information and avoiding significant image quality degradation. Data from the literature shows that up to 20% of MR imaging examinations have at least a repeat series, leading to the significant loss to a hospital. In most of the cases, a scanning technologist is the person who assesses the image quality and decides whether or not to repeat an acquisition. However, it is a radiologist who has final decision on whether images are sufficient to make a proper diagnosis. The need of rescan is especially problematic in outpatients as it creates a need for a patient recall, what definitely disorganize workflow and reduce patient satisfaction of service. Recently, a deep learning-based approach was developed, outputting a probability for a series to be clinically useful. The authors of this tool show that it can significantly decrease rescan and recall rates while rendering them technologies independent. We all know that appointment delays can decrease patient satisfaction. However, it is sometimes hard to maintain a schedule, especially when working in a busy center with a high load of emergency examinations like acute stroke or trauma. Curtis and coworkers have shown that machine learning models applied to radiology information system data can provide accurate and efficient wait and delay time predictors. Such accurate delayed and wait prediction may potentially increase patients' satisfaction. I have provided you an overview of recent advances in machine learning and deep learning within neuroradiology. There are many possible AI applications in this radiology subspecialty. Some of them have already been translated into commercially available products, performing tasks such as automated aspects calculation or intracranial hemorrhage detection. Other tasks, such as glioma genomics identification, are still in the research domain. However, I believe that they will be available for a daily clinical practice in the not so distant future. A question then arises: will our jobs be in jeopardy because of AI? I am not afraid of that, as differential diagnosis in neuroradiology, as in any other radiology subspecialty, is a very complex process. AI capable of end-to-end neuroimaging diagnosis will will require abilities to extract imaging features, process clinical notes, parselate neuroanatomy, construct differential diagnosis, recognize potential sources of artifacts, compare with prior studies, and many, many more. Even if achievable, such AI tools will still require substantial human oversight and supervision. Thank you very much for your attention.